Welcome to Amara Gavanini's weekly neurology update. This is our deep dive into the latest research that could impact, your clinical practice.
And just a reminder, this deep dive is purely for educational purposes.
Mm.
There's no commercial goal here at all. It's strictly a summary of the research paper we're discussing.
Absolutely. And we really do recommend you read the full paper yourself to get all the nuances and details. Today, we're digging into a study on serum neurofilament light chain, serum NFL, as a potential biomarker in chronic inflammatory demyelinating polyneuropathy, or CIDP.
That's right. This is based on the paper by Klimas and colleagues, which was published in Neuroimmunology Neuroinflammation in 2025.
So our mission today is to unpack what they found regarding serum NFL's role in, CIDP diagnosis, assessing severity, treatment outcomes, and importantly, what practical recommendations the authors are suggesting for everyday clinical practice.
Okay, let's start with the study design. It was a retrospective cohort study. They gathered data on 191 patients who had immune-mediated neuropathies, recruited from two different referral centers.
And how did that group break down?
So 110 of those patients had typical CIDP. Then there were 67 with atypical CIDP. The paper mentions the most common atypical types were distal acquired demyelinating symmetric polyneuropathy, multifocal acquired demyelinating sensory and motor neuropathy, and other atypical forms. And finally, 14 patients had other immune neuropathies, things like multifocal motor neuropathy, GBS, or paranodopathies.
And they had specific exclusions too, right? Things that could affect serum NFL levels.
Exactly. They were careful to exclude neurologic disorders known to raise serum NFL, so no amyotrophic lateral sclerosis, multiple sclerosis, neurodegenerative diseases, or acute cerebral ischemia or hemorrhage. They specifically mentioned excluding 3 patients due to that last one, the cerebral ischemia or hemorrhage.
Got it. And the main thing they measured was serum NFL.
Yes, but crucially, they didn't just use the raw serum NFL values. They calculated age-corrected and body mass index-corrected serum neurofilament light chain Z-scores. We'll call that serum NFL Z-score.
And that correction is important because
Because age and BMI themselves can influence serum NFL levels. Using the Z-score helps remove that bias, giving a clearer picture. They also used a range of clinical scales to assess the patients.
which ones?
Let's see, the INCAT Overall Disability Sum Score, the INCAT Sensory Sum Score, the MRC Strength Scale, the RDS, and the Modified Rankin Scale.
Standard measures. What about electrophysiology?
They performed nerve conduction studies using standard methods. They maintained specific temperatures, at least 33 Celsius at the palm, 30 Celsius at the external malleolus, and did bilateral studies on the median, ulnar, radial, tibial, fibular, and sural nerves. These results were then compiled into an electroneuropathy score, though it's worth noting something they found later. The serum NFL Z-score didn't actually show significant correlations with this electroneuropathy score or the tibial CMAP when they analyzed the typical CIDP cohort separately.
Interesting. And how did they define early versus late disease for their analysis?
Early stage was defined as less than 24 months since the first manifestation of symptoms. Late stage was more than 24 months.
Okay, let's unpack the correlations they found, looking at the whole group first.
Yes, for all 191 patients combined, the serum NFL Z-score showed several significant correlations. It correlated significantly with the INSACT Overall Disability Sum Score.
What were the numbers on that?
The correlation coefficient, RR, was 0.160, and the p-value was 0.002. It also significantly correlated with the MRC Strength Scale score, R equal to 0.242, P equals 0.001.
Negative correlation there. Makes sense.
Right, and a significant correlation with the modified Rankin scale score, RR 0.151, P equals 0.014, also with distal tibial CMM, R and equals 0.151, P equals 0.039, and finally with the electronography score, R 0.140, P equals 0.027.
So across the board, higher serum NFLZ score linked to worse clinical and electrophysiologic measures. But you mentioned a caveat.
Yes, and this is really a key finding. These significant correlations, they only remain significant when the researchers analyze the typical CIDP cohort separately.
Only in typical CIDP.
Correct. In the atypical CIDP group, they found no significant correlations between serum NFLZ score and these clinical measures.
Did they report any non-significant findings overall?
Yes, they mentioned that overall there was no correlation found between the RDS sum score or the INCAT sensory sum score and the serum NFLZ score.
Okay, now this is where it gets really interesting, isn't it? The differences they saw between typical and atypical CIDP, particularly early on.
Exactly. When they looked specifically at patients within the first 24 months of symptoms, they found that those with typical CIDP, that was 27 patients in this early group, had significantly higher serum NFLZ scores. The mean serum NFL z-score was 1.6, standard deviation 1.7.
And how did that compare to early atypical CIDP?
Significantly higher. The atypical CIDP group, 14 patients early on, had a mean serum NFL z-score of 0.4, standard deviation 1.4. The p-value comparing them was 0.028.
So a real difference there. Did they look at serum NFL z-score over time within typical CIDP?
They did. Within the typical CIDP group, the serum NFL z-score was significantly different between that early stage group, the 27 patients, and the late stage group, which had 83 patients. The early mean was 1.6, like we said, while the late stage mean dropped to 0.5, standard deviation 1.5. The p-value for that difference was 0.002.
So levels seem higher earlier in typical CIDP.
It seemed so. And importantly, this negative correlation with time since onset was only observed in the typical CIDP group.
What about clinical severity? Was that also different between the groups early on?
Yes. In that early phase, less than 24 months, patients with typical CIDP were significantly worse off on several measures compared to those with atypical CIDP. The INCAT overall disability sum score showed a significant difference, p-equals 0.036. CMAP values were worse, p-ln 0.00399. And the RDS sum score was significantly lower, indicating worse function, p0.0012.
So a typical CIDP seems to present more severely early on and with higher serum NFL z-scores. What does this mean for using serum NFL z-score diagnostically?
Well, they ran an ROC analysis specifically for differentiating typical versus atypical CIDP in that early stage, using data from 41 patients. They tested different serum NFL z-score thresholds. What they found is a threshold of 2.04 had a high specificity, 93%, for identifying typical CIDP, but the sensitivity was lower, only 37%.
Okay, so good at ruling in typical CIDP if it's high but misses a lot of cases. What about the other way around?
Right. Conversely, a serum NFL z-score less than 2.04 had 93% sensitivity for identifying atypical CIDP, but again, only 37% specificity.
So how should we interpret that practically?
The authors suggest that a serum NFL z-score below 2 might be quite reliable for confirming atypical CIDP if that's what you already suspect based on clinical grounds. But a high serum NFL z-score, while very specific for typical CIDP, isn't sensitive enough by itself to rule it in. You still need the other clinical and electrophysiologic evidence.
Makes sense. Let's move on to disease severity. They use that serum NFL z-score threshold of 2 again, right?
Yes. They compared patients with a serum NFL z-score greater than 2, the high group, versus those less than 2, the low group. Across a whole CIDP cohort that was 34 high, 143 low, the high serum NFL z-score group had significantly more severe disease.
On which measures?
On the INCAT overall disability sum score, p=0.01. On the MRC strength scale, p=0.06. And on the RADIA sum score, p=0.048. And this finding held true when they looked just within the typical CIDP cohort as well. That was 24 high, 86 low. The p-values there were similar. 0.016 for INCAT overall disability sum score, 0.006 for MRC strength scale, and 0.047 for RDS sum score.
But this link wasn't seen in atypical CIDP.
No, again, this association between high serum NFL z-score and greater severity was specific to the typical CIDP cohort in their analysis. They also did an interesting comparison. Typical CIDP patients with high serum NFL z-score versus atypical CIDP patients with low serum NFL z-score.
What did that show?
The typical CIDP patients with high serum NFL z-score were significantly weaker. Their mean MRC strength scale score was 64, standard deviation 12, compared to 75, standard deviation 5, in the low serum NFL z-score atypical group. P-value 0.00067. Their RDS sum scores were also significantly lower, mean 48, standard deviation 22 versus 71, standard deviation 18, p-value 0.0032. The INCAT overall disability sum score showed a trend, with a median of 4 in the typical high group versus 2.5 in the atypical low group, but the p-value was 0.068, so just missing statistical significance there.
Does the high serum NFL z-score point more towards motor or sensory problems?
It seems primarily linked to motor impairment. They analyzed this based on MRC strength scale and INCAT sensory sum score. Patients defined as having motor impairment, meaning an MRC strength scale score below 70, had significantly higher serum NFL z-scores. Their mean serum NFL z-score was 1.29, standard deviation 1.45. Compared to those with preserved motor function, whose mean serum NFL z-score was much lower, 0.11, standard deviation 1.03, the p-value for that difference was 0.0035.
When was that also specific to typical CIDP?
Yes, it was. This link between motor impairment and high serum NFL z-score was significant in typical CIDP, p=0.0262, but not in atypical CIDP, where the p-value was 0.7034. They also noted that patients who had significant sensory involvement defined as an INCAT sensory sum score of 10 or more, but who had preserved motor function, actually had serum NFL Z-score levels similar to healthy individuals.
So the takeaway is that high serum NFL Z-score in the CIDP context seems mainly driven by motor axon damage.
That appears to be the main driver, yes.
Okay, let's talk treatment response. What did they find for those patients identified early on with high serum NFL Z-scores?
They specifically looked at the early stage typical CIDP group, less than 24 months for onset. They compared the 10 patients with high serum NFL Z-score greater than 2 to the 17 patients with low serum NFL Z-score less than 2. And they looked at how many were refractory to standard of care treatment.
Standard of care being corticosteroids and IVIG or SCIG.
Correct. And refractory meant needing second-line or escalated treatments.
Yeah.
So before the serum NFL Z-score was actually measured, about 30% of the high group were already standard of care refractory compared to 12% of the low group. That difference wasn't statistically significant yet, p equals 0.24.
But
Then, at the time the serum NFL Z-score was measured, the difference was, well, stark. 0% of the high serum NFL Z-score group were standard of care refractory.
80% compared to...
Compared to only 6% of the low serum NFL Z-score group. The p-value there was less than 0.01. Highly significant.
Wow, that's a dramatic difference. Did it persist?
It did. 1 year later, 90% of that high serum NFL Z-score group were standard of care refractory compared to just 8% of the low group. Again, p-value less than 0.01.
So the implication is pretty clear there.
Very clear. Patients with typical CIDP presenting early with a high serum NFL Z-score were significantly more likely to fail standard treatments and require escalation.
Did they follow any of these high serum NFL Z-score patients longer term?
They did have some limited longitudinal data. They followed 9 of those early-stage typical CIDP patients who had a high serum NFL Z-score, greater than 2, for about 1 to 3 years.
And what happened to their clinical scores over that time, presumably with more aggressive treatment?
Well, their INCAT overall disability sum score improved, but it wasn't a statistically significant change over that period. However, their RES sum score, measuring functional ability, did show significant improvement compared to their baseline. That improvement was significant after 2 years, p equals 0.026, and also after 3 years, p equals 0.023.
What about strength and nerve conduction?
The MRC strength scale showed a trend towards improvement. P-values were around 0.056 and 0.059 at years 1 and 2, but it didn't quite reach statistical significance. And the tibial CMAP measurements didn't show any significant improvement or worsening during that follow-up.
So despite being more severe initially and often refractory to standard care, these high serum NFL Z-score patients could still show clinical improvement, especially on functional scales like RES, with presumably escalated treatment.
That seems to be the case, based on this small group, yes. They weren't treatment unresponsive, just standard of care refractory more often.
Okay, pulling it all together, what practical recommendations did the authors make based on these findings?
They laid out 4 main points for clinical practice. First, they recommend measuring serum NFL at the time of diagnosis for suspected CIDP, and importantly, expressing it as the serum NFL Z-score.
To account for age and BMI.
Exactly. Second, they suggest serum NFL Z-score can help differentiate between typical and atypical CIDP at diagnosis, suggesting that threshold of 2 we discussed. Third, a serum NFL Z-score greater than 2 in someone with typical CIDP seems to identify patients who are at risk due to high disease activity.
And the fourth point relates to treatment.
Yes. Based on the refractoriness data, they recommend that early aggressive treatment should be considered for patients who present with typical CIDP and have a serum NFL Z-score greater than 2 right at diagnosis.
Of course, every study has limitations. What did the authors point out here?
They acknowledged a few key ones. A major limitation is the lack of longitudinal serum NFL measurements for most patients. This prevents a full picture of how levels change over time with disease course or treatment. They also noted the small sample size for some subgroups, particularly atypical CIDP patients with high serum NFL Z-score or early onset, which impacts how generalizable those specific findings might be.
Anything else?
Yes, the analysis didn't explicitly control for patient stability or the specific therapies individual patients received, and both of those factors could potentially influence serum NFL levels independently.
Okay, let's try to synthesize this. The study suggests that serum NFL Z-score looks like it could be a genuinely useful tool, especially in typical CIDP. It seems to offer value in assessing disease activity early on, maybe even predicting who might not respond well to standard treatments, and thus guiding intensity.
Right. It really reinforces the idea that the significant axonal damage isn't just a late-stage phenomenon in typical CIDP. It can happen early. And having a biomarker like serum NFL Z-score to pick up on that early severity could be crucial for intervening more effectively and potentially improving long-term outcomes.
So for you, the clinician listening, what's the bottom line? Measuring serum NFL Z-score might become a more standard part of the CIDP workup. It could help you refine the diagnosis between typical and atypical forms, and maybe, just maybe, flag those typical CIDP patients who warrant a more aggressive treatment strategy right from the start.
It's certainly thought-provoking data pointing in that direction.
Which leads us to our final provocative thought for you to consider. If a high serum NFL Z-score in early typical CIDP really is a strong indicator for needing treatments beyond standard care, could routine serum NFL testing at diagnosis fundamentally change how we approach these patients initially? Could we see a shift towards a biomarker-driven algorithm where that high serum NFL Z-score automatically triggers consideration of, say, second-line therapies much earlier than we currently do? Something to mull over. That's our deep dive for this week. Please join us next time on Amir Gavanini's Weekly Neurology Update.